to wonderful fellows and hem-onc fellows in India. My name is Aman Chauhan, one of the assistant professor of medicine at Markey Cancer Center, University of Kentucky. And neuroendocrine tumors and neuroendocrine neoplasms, to be more precise, are my area of clinical and research expertise and honestly my passion. And recently I've been bestowed with honor of directing our PRRT program for neuroendocrine tumors at Markey Cancer Center. So today, I would like to basically give a broad overview about neuroendocrine cancers and specifically talk about recent advances, especially the advances which have changed practice rather than more academic or drugs in development. I'll talk more about the standard of care changing trials and practices. And for this particular talk, neuroendocrine cancer is a big field, and these are heterogeneous cancers, a group of different type of cancers. But for today's talk, we'd like to focus more on gastroenteropancreatic neuroendocrine tumor and lung neuroendocrine cancers, both low-grade and high-grade neuroendocrine carcinomas. I will not be talking about cancers like small cell carcinomas, be it lung, small or extrathoracic small cell carcinoma, paraganglioma, Merkel cell, pheochromocytomas. These are also type of neuroendocrine cancers. Some are low grade like pheos and paras, and some are high grade like small cells and Merkel cell. But we won't be talking about those cancers in today's talk. In general, the talk could be divided between advances or recent updates in epidemiology, pathological classification, tumor genetics, diagnostics, and treatment. This is one area of oncology where we've really seen changes in almost all of these fronts, and as I walk you through, you'd be very pleasantly surprised with all the advancements and strides we have made in the last 5 to 10 years. So just a brief primer, what neuroendocrine tumors are. Neuroendocrine tumors are a group of rare tumors which can arise from anywhere in the body. Okay, they arise from these specialized cells called neuroendocrine cells. For example, enterochromaffin cells in the gut. Right, the incidence is pretty low, but prevalence is very high because most of these neuroendocrine cancers are indolent, and that means they fortunately a lot of our patients live for a long time, so the cumulative prevalence is very disproportionate to incidence. Treatment options are limited as compared to your breast cancer or the colon cancers or some other GI malignancies. However, we have seen the needle moving in that area, and as we talk further, you'll be happy to see that there have been few new FDA approvals in our field. Okay, so let's talk real quick about updates in epidemiology, right? Everybody's favorite topic. No, I'm just kidding. Alrighty, this is a landmark paper from JAMA Oncology, colleagues from MD Anderson, Dr. Dasari. He recently published the updated SEER database view. SEER is one of cancer epidemiology database, and it's a pretty high quality cancer statistics database. And as you can see, the top line in blue, it represents the cancer incidence of all major malignancies, be it colon, lung, GI cancers, for past 40 years, so 4 or 5 decades. And initially, when about 3 decades, there was slight increase in the incidence. Then we started seeing some decline in the incidence, probably because of lesser people smoking and colonoscopies. But overall, the incidence for major malignancies has remained plateaued, which is good. We would like to see these decline, but it has kind of remained plateaued. On the contrary, if you see the bottom line in the yellow, that's the neuroendocrine tumor incidence. It used to be 1 per 100,000 or a million cases back in 1973s. And fast forward to the most recent data we have in this publication is 2012, where we are talking about 5.5 cases per 100,000. it is expected that the current incidence is probably 6 to 7 per 100,000. So there is a linear incline in the incidence. This is quite stark to all other cancers. Well, a lot of people ask me, why is it so? And clearly there is this improved diagnostics. We are scanning more people. We are doing more colonoscopies. And we are finding most of these early stage cancers. However, is that all? And that's a question which needs to be researched. And if we continue to see this pattern, that the incline in neuroendocrine incidence continues for next decade, I think we would be compelled to look into environmental factors, because our diagnostics are not improving at that rate to really justify continued increase of neuroendocrine tumor incidence. This got me curious about checking our own database in Kentucky Cancer Registry, which is also a subsite of a SEER database, one of the nodal registries in the SEER database. And unfortunately, our neuroendocrine tumor incidence are even higher than the national averages. At the time of when we compiled the data, our incidence was about 10 per 100,000. And as Dr. Matthews here, and he's worked with the Markey Cancer Center in past, he can attest to it. We served an underserved population, rural Appalachian population. So these patients, unfortunately, have limited access to healthcare. Kind of can similar to a lot of patients in India. So not only we are seeing increased burden on these patients in Kentucky and rural Appalachia, but sometimes the limited access to care or enough adequate doctors can also compound these issues. So recently I wrote an op-ed in JAMA Oncology with the intent to raise awareness about neuroendocrine cancers. A lot of people don't know about it, or if they know about it, they know vaguely about it, and they always brush it under as one of those rare cancers that they don't have to deal with it. I wanted to break that perception, and what basically want to be published here. I looked into the SEER database and kind of reported the cumulative prevalence. And you'd be surprised to know neuroendocrine cancer is actually second most prevalent GI cancer, right after colorectal, right? So after colorectal is neuroendocrine, more than pancreatic, more than hepatobiliary, more than esophageal, right? Now, agreed. There would be a subset of these patients which were caught early stage and probably underwent curative resection, and they're okay. But there is a big chunk of population with metastatic disease. So we need to know about this condition. Unless we know, we would not be able to devise more treatments and monitor them and provide better care to these patients. So that was neuroendocrine tumor statistics for GI. What about lung? If I have to divide neuroendocrine tumors based on the prevalence on the site, the gastroenteropancreatic definitely the most prevalent, but after that, it's the lung neuroendocrine tumors is the second most prevalent site for neuroendocrine cancer in the body. And if I have to divide all the lung neoplasms, these neuroendocrine cancers actually together, almost form 1/4 of the pie, maybe a little less, 20% of the pie. Small cell lung cancer is a type of high-grade neuroendocrine cancer. But today we will be focusing on low-grade neuroendocrine tumor carcinoid, which forms about 2%, and large cell neuroendocrine cancer, which is a high-grade neuroendocrine carcinoma, a sister cancer in a sort of small cell lung cancer, forms about 3% of thoracic neoplasms. A couple of years back, we also looked at our Kentucky Cancer Registry database, specifically focusing on large cell neuroendocrine cancer. And what we found that over a period of last 10 years, the incidence had almost doubled as a percentage of all neoplasms. So clearly, either we are recognizing this rare condition more, or there's truly an increase in incidence of these neuroendocrine cancers for reasons that we don't understand yet. However, the bottom line is increasing incidence of these rare neuroendocrine neoplasm mandates spreading awareness among general population, educating our colleagues in community, and fostering medical research. So that's why I always start with epidemiology, because unless we understand the burden of disease, we would not be able to take the field forward. Okay, moving forward, let's talk a little bit about classification and pathology. Um, we have seen a tremendous amount of development in this area as well. This is a relatively newer field of cancer as compared to lung cancer or colon cancer, and these WHO classifications were kind of formulated relatively recently. So, if I have to broadly classify neuroendocrine neoplasms, so neuroendocrine cancers are a spectrum of disease. It's not one disease, right? So you can classify neuroendocrine neoplasms into low-grade spectrum, would be more well-differentiated neuroendocrine tumor, and on the more aggressive spectrum would be high-grade neuroendocrine cancers like poorly differentiated neuroendocrine carcinoma. So how do we differentiate? We are moving away from those old terminologies of carcinoid tumor because they were very confusing. Okay, so I want everybody to learn that we need to make it very standard to use the newer nomenclature using neuroendocrine neoplasms, and there are two different types: well differentiated neuroendocrine tumor or poorly differentiated neuroendocrine carcinoma. The key word which makes them very different is tumor versus carcinoma. Okay, and neuroendocrine tumor can be of three subtypes based on the grade of neuroendocrine tumors: grade 1, grade 2, and grade 3. Neuroendocrine carcinoma, on other hand, are always grade 3. There are no low-grade neuroendocrine carcinomas. Okay, so by definition, neuroendocrine carcinoma are very aggressive cancers. And the examples of these neuroendocrine carcinomas would be small cell carcinoma, large cell neuroendocrine carcinoma, or poorly differentiated neuroendocrine carcinoma. You can't really elaborate further whether they are small cell or large cell histology because they're so anaplastic and necrotic. So, and there is another entity called menin, which is mixed neuroendocrine, non-neuroendocrine neoplasia. Okay, so the some of you folks who are savvy about neuroendocrine tumors, you've probably been following this nomenclature. This was introduced in 2010 by WHO, and then this mixed neoplasm, menin, used to be known as manic, which was mixed adenoneuroendocrine neoplasm. But later on, we realized that it's not necessarily just adenocarcinoma is mixed with neuroendocrine; it could be other histotype as well. And recently WHO revised that terminology from manic to menin. It could be mixed neuroendocrine, non-neuroendocrine neoplasm, as long as you have 30% or more of the other histotype present in the tumor. Okay, let's delve a little bit more detail into it because pathology is the key. If we don't have a good grasp on pathology for neuroendocrine cancer, we will get the diagnosis wrong and we will put the patient in the wrong treatment altogether. So this is a classic well-differentiated low-grade neuroendocrine tumor. You can see round, very homogeneous-looking cells, and they stain for chromogranin, synaptophysin, and the middle slide shows you staining for Ki67. This is how we grade these neuroendocrine tumors, right? So the Ki67 is very sparsely taken, so that means these cells are not rapidly dividing. So Ki67 is low, okay? And usually we see if Ki67 less than 3%, it's grade 1. It's between 3 to 20% is grade 2, okay? On the contrary, look at this high-grade neuroendocrine carcinoma slide, right? And on one side, you see a very poorly differentiated, maybe large cell morphology. On this side, you're seeing more small, round, blue cells, like oats. So this is small cell carcinoma, right? And in the middle, we are again looking at the Ki67 staining, and you can see there's just intense amount of uptake in Ki67. That tells you that these cells are proliferating really fast, so they're taking up all the Ki67, right? So this is very high Ki67, right? In my experience, by definition, high-grade neuroendocrine carcinoma, they'll all have Ki67 more than 20%, but in reality, this small cell lung cancer or large cell neuroendocrine carcinoma, they usually, you see the Ki67 over 50s, over 60s, over 70, in that range, okay? So in 2010, this is what WHO did. They wanted to streamline how we diagnose neuroendocrine tumors so that we can, institute a better plan for not only treatment but surveillance. So they classified neuroendocrine tumor into three groups. Grade 1, based on mitotic index, if less than 2 mitoses per 10 high power field or less than 3% Ki67. Grade 2, if it's 2 to 20 mitoses for 10 high power field or 3 to 20% Ki67, okay? And if it's more than 20 for both, was classified grade 3. And all grade 3 used to be thought as poorly differentiated. So basically, we only had grade 1 and grade well differentiated, and all grade 3s are poorly differentiated. Then what happened? As more people studied neuroendocrine cancers, and we realized not all grade 3s are same. Okay, within the grade 3s, there are some good actors and there are some really bad actors. Okay, by that I mean aggressive biology and behavior of the cancers, right? So this is a very good study done by Dr. Tang. This is a very eminent pathologist from Memorial Sloan Kettering. And she looked into the different grades of neuroendocrine cancer, especially pancreatic. And as you can see, these both green, the blue and the red lines, they represent high-grade neuroendocrine cancers. But the red ones are, in particular, you see the outcome is pretty bad, okay? So when they looked into these and correlated the pathology, they realized that it's the morphology which is really critical for these high-grade neuroendocrine cancers, right? So if you have well-differentiated morphology, they might do worse than your low-grade neuroendocrine tumors, but they are still far better in terms of overall prognosis as compared to neuroendocrine carcinoma. Okay, so morphology is really critical here. So if you are dealing with a large cell neuroendocrine cancer or small cell cancer, those patients unfortunately have a really poor outcome, and we really haven't made a big dent in the way we treat them over the past 3 decades. But the high-grade, well-differentiated histology tend to do somewhat better. Okay, and this again is an area of growing interest, and people are trying to research is what should we be treating these patients with. Should we treat them with platinum-based chemotherapy like high-grade neuroendocrine carcinoma, or should we treat them more like low-grade with somatostatin analogs, etc.? So we'll get into that in a bit. So based on this growing evidence of data, WHO revised the classification in 2017. And now, unlike the previous classification where all grade 3s were poorly differentiated carcinoma, now you had some grade 3s which can be well differentiated. And so there's a complete new category added in 2017 WHO classification. So now well differentiated neuroendocrine tumors can be grade 1, 2, 3 based on Ki67 index or mitotic index. Okay. And the poorly differentiated neuroendocrine carcinoma, they're always grade 3 because we know they're always over 20%. Okay. So morphology is key. Anytime you see a neuroendocrine cancer patient, look at the pathology, see what the morphology is. Is the pathologist alluding to neuroendocrine tumor or neuroendocrine carcinoma? That's your first point of division, which will help you decide, am I going to get a gallium scan or a FDG PET scan, right? So just giving you an example. Alrighty, moving forward. This picture is kind of summarizes how knowing the pathology really helps us fine-tune our management for these cancers. Okay, so just like I was mentioning, a low-grade, well-differentiated neuroendocrine tumor, you would notice that these patients would have somatostatin receptors. So you would like to get a somatostatin receptor scintigraphy or imaging like gallium dotatate scan or octreos scan. Okay, and you would treat them with low-grade neuroendocrine tumor regimens like somatostatin analog or mTOR inhibitor like Afinitor or Sutin, as compared to the higher grade segment with poorly differentiated neuroendocrine carcinoma. They rarely have somatostatin receptors. Some of them can, but they rarely. So you would rather order an FDG PET because you're looking for very hypermetabolic lesions, right? And you would treat them with the cytotoxic chemotherapy. The most well-studied regimen in this case is platinum doublet, right? Now, the well-differentiated grade 3 and the intermediate grade 2s or low Ki-16 grade 3s, those are the areas where we are still struggling, and it's evolving field, and we're trying to see how can we improve treatments for those patients. All right, guys, you're all with me, feeling like drowning? Okay. Now, from here on, I think everything is more clinical and treatments and, oh, well, sorry about that. A little bit more pathophysiology first, okay? So what do we already know about neuroendocrine tumors? We all know that these cancers are a little bit unique from other cancers because they have somatostatin receptors. I'm talking more, especially more for well-differentiated low-grade neuroendocrine tumors, right? And we have leveraged this property of neuroendocrine tumors having somatostatin receptors to the max, from diagnostics to the treatment, and most recently theranostics, and we'll talk about that in a second. But besides the fact that neuroendocrine tumor cells express somatostatin receptors, different families and different types, we also know one of the major pathways involved and responsible for growth of these neuroendocrine cancers is called mTOR pathway. And we have also leveraged that, and we have targeted that, and we have FDA-approved treatment now, which is Afinitor or everolimus for the management of neuroendocrine tumor, right? So this is what's known, well known for past 10, 15, 20 years. But moving forward, I think where are the advances I was talking about? I think in last 5 years, we have really learned about the molecular genetics and molecular fingerprinting of these cancers. And we finally caught up, or we are trying to catch up with other major cancers in understanding driver mutations, or how do they look, molecularly, right? And again, this is from 2015. I was still a fellow at that point in time, and molecular sequencing was very new and upcoming in neuroendocrine world at that point in time. And Dr. Tang, she kind of made this observation because, as you all know, Memorial used to be, and it still is, the leader in sequencing most of these cancers, but they were really sequencing all the solid cancers for a long time, much before most of the cancer centers did. And they had this program called MSKCCI Impact, where every single cancer patient had access to sequencing. So they had this wealth of data where they studied different cancer types. And in this particular cancer, what they realized that there are two different signature patterns in high-grade versus low-grade neuroendocrine tumors. Grade 1, grade 2 neuroendocrine tumors tend to have DAX-ATRX mutations, as compared to PD or high-grade neuroendocrine cancer, which tend to have more P53 mutation, loss of RB, and SMAD. Later, Dr. Reedy, who's also a medical oncologist and a neuroendocrine tumor expert from Memorial, she presented her findings at NANETS, and these are NGS reports or data from neuroendocrine cancers, all from low grade to high grade. And as you can see, this patient population is grade 3 poorly differentiated neuroendocrine cancer, and they tend to have either loss of RB1 or TP53 mutation, but you don't tend to see the common neuroendocrine tumor mutations like MEN or DAX, ATRX. But if you move to well-differentiated neuron high grade, you see a clear difference that you don't see those TP50 RB1, which is actually a very classic signature for small cell lung cancer. If you know, in 99% of all small cell lung cancer would have TP53RB1 co-mutation, right? So so now we are understanding we can actually leverage this molecular information to help us with further characterization of these cancers, especially in these high grade or grade 3 well differential, where sometimes it could be a little confusing. We are also understanding that these mutations can potentially be more prognostic and predictive. These are very early data, and of course, the numbers are very small, but hypothesis generating. This Dr. Nityaraj from Memorial published in JCO, and as you can see, certain mutation seems to confer better outcomes. So DAX-ATRX mutation, mutated neuroendocrine tumor patients tend to do better as compared to wild type, and also MEN mutated tend to do better. It's just counterintuitive, but that's what they noticed. So if you tend to have MEN mutation, these patients had better prognosis than the wild type. As compared to BRAF, so if you are BRAF mutated, you tend to do well. This is a well-known phenomenon in various cancers. Um, in fact, when I was fellow with Dr. Matthew, I think we had a patient with colon cancer, BRAF mutation. I was asking him, hey, this is so bad. So BRAF mutation seems to confer bad prognosis in different cancer types. So same trend we are seeing in neuroendocrine tumors as well. And so what I want to tell you that I think we are learning a whole lot every single day about molecular information and how this might impact how we look into these patients and overall outcome. And where this might actually end up down the road and not too far in distant future is that the molecular sequencing or signatures might actually be incorporated in the next iteration of WHO classification. I would not be surprised if this becomes a part of standard classification. Okay, so stay tuned. I think this is happening sometime. I'm hoping next 5 to 10 years. Okay. All right. So I like to kind of throw in here and there what I'm doing here, taking this piece of information and trying, my bit to advance the science here. So about a year and a half back, I got a small grant called KL2 grant to study these high-grade neuroendocrine cancers, and I was building on a hypothesis that not all high-grade neuroendocrine cancers, as we know, are homogeneous. So you can actually subdivide them into two subcohorts: is TP53RB1 co-mutated subcohort versus non-co-mutated subcohort. At least in the United States, most doctors with high-grade neuroendocrine cancer treat them like small cell lung cancer. So my hypothesis is, do all need to be treated like small cell, or should we use adeno regimens for the patients who don't have this classic small cell signature like TP53RB1? So I'm happy to tell you those protocols finally went through. I think it should be up on clinicaltrial.gov in a day or two, and we hopefully start enrolling on this trial. This is a pilot study in about 2 or 3 months. Okay. All right. So we now know about neuroendocrine tumors, what they are, how they look under the microscope, how the burden of disease is increasing in society, and we also know a little bit more molecular biology of neuroendocrine tumors. Let's talk a little bit about, have we advanced our diagnostic capabilities of neuroendocrine tumors? And the answer is yes to that as well. Okay, so neuroendocrine cancers in past used to be misdiagnosed and delayed diagnosed. It's very common for patients to get labeled as completely a benign disorder based on the symptoms, because neuroendocrine cancer symptoms can overlap with a lot of other common medical problems. As you can see, this graph or this chart figure shows the common symptoms being flushing, diarrhea, fatigue, weight loss, asthma-like symptoms, and these are non-specific. These can be seen in a lot of other common problems, and one of the common issues with most neuroendocrine tumor patients can attest to that is delay in the diagnosis. They keep running between gastroenterologist to endocrinologist, etc. Um, I got this weird graphics on my screen. I don't know. Okay, perfect. Thank you. Um, so here is an example. This is a series which I compiled when I was a resident in LSU doing medicine. At that time I wasn't in a heme fellow, so I got interested in neuroendocrine tumors back when I was doing MD in medicine, right? And we looked into a very rare subset of neuroendocrine cancer called DIPNISH, which is diffuse idiopathic permanent neuroendocrine cell hyperplasia. Okay, and one thing which was very common in most of these patients was a significant delay in diagnosis. These patients were treated for asthma or COPD for the longest time period you can imagine. Of course, their symptoms did not resolve with your standard asthma treatment or COPD treatments, and so there was a significant delay in treatment. So it's really important to pick these patients early, take their symptoms seriously, and my first slide had a zebra there, and the zebra is our mascot for neuroendocrine cancers. So in medicine, when you hear hoofbeats, think horses, not zebras. It's quite the opposite for rare cancers. For us, we have to think zebras, otherwise we miss these zebras. All right. So moving forward, one of the reasons why people used to get missed or these diagnoses were not accurate, because back in the days before the WHO got their act together and streamlined this whole classification, um, there was such a big discordance even between the pathologists how to diagnose, and it's well published that even pathologists disagreed with the diagnosis. Fortunately, I think it has changed now, and the diagnosis is pretty straightforward with the WHO classification and the very standardized nomenclature. I think that problem is probably more in past and historical. Have we made any improvement in diagnostics in terms of lab tests and biomarkers and tumor markers? Well, neuroendocrine tumors unfortunately suffers from not having a very sensitive and specific biomarker. Some of the patients, some of the neuroendocrine tumor patients tend to be functional. That means they can produce a hormone, right? These are minority. 20 to 30% of all neuroendocrine cancer patients can be functional, and the kind of hormones they produce, it can vary, but the commonest one is serotonin. So you've heard about carcinoid syndrome, and excessive production of serotonin causes flushing, diarrhea, and wheezing. But this is just one of the many hormones neuroendocrine cancers can produce. The other common ones would be gastrin, so gastrinoma, VIP, vasoactive intestinal peptide, pancreastatin, insulin, glucagon, somatostatin. So there are n number of hormones. Some of the hormones we don't even know yet. Okay, so if they are producing these hormones, then certainly we can check those hormones and monitor the disease that way in a very crude way. The other biomarkers are chromogranin A. You've all heard of it. It is a very valuable tool in IHC in establishing histopathological diagnosis, but is a very not sensitive or specific biomarker. And you can see chromogranin to be elevated even if somebody is taking H2 blockers or PPI or antacid or other things. Okay. So there's clearly a need for us to develop better biomarkers, but for what it's worth, chromogranin A is the biomarker of choice for low-grade neuroendocrine tumors, grade 1, grade 2. And for high grade, sometimes we do NSC, which is neuron-specific enolase. But to be honest, most of these biomarkers not really helpful besides serotonin and urinary 5-HI, which can help monitor their serotonin levels, because you want to control that with your treatments, right? However, lately there's been this brand new blood-based molecular biomarker seems to have a great science behind it, very high impact publications, including Lancet, Oncology, and a host of publications. So To be honest, I have not had a lot of experience with this biomarker myself, but I've read a bit about it, and it's been in the field for now, I think 5 to 6 years now, and slowly getting more traction. And this is just one of the papers I picked up to tell you all about what it is. It's a multi-gene assay. I think they're using 51 genes, and it has a couple of different uses. One is very sensitive and specific for diagnosis of neuroendocrine tumor. As you can see in this particular figure, it's a real world, I think registry-based study of 100 neuroendocrine tumor patients published in Oncologist. And these patients who had a diagnosis of neuroendocrine tumor, chromogranin was elevated only in 25%, while net test was elevated in almost all of them. So very high diagnostic accuracy. But moreover, this test is also being looked in from prognostic and predictive standpoint as well. In this particular pie charts, what we are trying to see is if the net test report net test is reported as either low score, intermediate score, and high score. And I think median time of follow was at least 6 months in this large 100 patient cohort. So the patients with had progressive disease, they were also the ones which had high net test score. And the patients who had stable disease, they were also the ones which had low net test score. How does it help us in clinical practice? As you all know, there are a cohort of patients where we employ this technique called wait and watch, right? Because some of these patients are really indolent and they're not progressing, and you don't want to start treatment too early, if they're not progressing. So maybe net tests can help us in following these patients and see how often do we need to scan them, and then do the risk management triage, how to kind of have a surveillance strategy for these patients. I'm not sure. This is a hot topic in our field, and but the science is really good, and I would encourage all of you all to read about these. And this might become more and more mainstream in the near future. And just to kind of end up the biomarker section with something, a cute little project we did last year. So I was at AACR in Atlanta last year and bumped into the investigator from Switzerland, and they were researching progastrin. And intuitively, I thought progastrin has to do with something with neuroendocrine, right? Gastrin. And they had no clue about researching this in neuroendocrine tumor. They had really strong data where they had validated this biomarker in colon cancer and other GI solid tumors. So I was very excited and eager to explore that in neuroendocrine cancer populations. We did a small pilot study, and happy to share. We presented this data at GI ASCO earlier this year. This is pre-COVID. Things were back normal. Who would have thought this different world in January? And then we did find statistically significant difference as compared to normal healthy cohorts. And these are not error bars, so just warning. These are box with plot, so this is just the range. But the medians had significant difference. So building on this pilot, we are now shipping 100 more samples next month to Switzerland to confirm these findings. But it's really exciting that as simple as this 80 amino acid molecule progastrin, which is a precursor of gastrin, can be a very sensitive biomarker for monitoring. Alrighty, moving on to the most critical of the diagnostic updates, and where we really have made a difference, is the imaging, right? On your left-hand side, you see an old scan, which used to be pretty helpful for good 20, 30 years, I think, and it's called OctreoScan. But now we have a much better, more sensitive scan called gallium dotatate scan, right? So if you have a neuroendocrine tumor, well differentiated, low grade neuroendocrine tumor, the hypothesis is you tend to have a lot more higher density of somatostatin receptors. Now imagine if you can um, radio label somatostatin analog, you can actually pick all these somatostatin tumors, and this is what gallium dotatate scan did. So you have gallium 68, which is a radio tracer attached to dotatate somatostatin analog, and it goes wherever in the body there is somatostatin receptors, right? You can see all those small mets in the livers and the bones. Okay, and this scan is pretty good. I mean, it doesn't get better than this. Sensitivity and specificity both close to 90-91%. So very good for well differentiated low grade neuroendocrine tumors. And based on these stellar results, FDA approved it. I think this was back in maybe 2016. And since then, at least in Marquee alone, we have done over 700 scans for gallium scans. And I think a couple of years back, we presented our first 200 scan data. So, just in brief, how we use gallium dotatate scan, every well differentiated low grade neuroendocrine tumor gets a gallium scan. As you can see, this is our neuroendocrine tumor program here. So this is a very pivotal step. And based on this helps us figure out the burden of the disease. It also helps us pick up a primary site in a lot of these neuroendocrine tumor. Unknown primary helps our surgeon plan a better resection. They have a better idea. It helps our interventional radiologist plan the embolization better than just a pure anatomic scan. So gallium scan in general does help in fine-tuning our management for neuroendocrine tumor patients. But of course, the most important part of gallium dotatate scan is that it confirms whether there is somatostatin receptors or not. And why is that important? Because we now have a brand new treatment for neuroendocrine tumors called PRRT, which for which to qualify, you have to have a positive gallium dotatate scan. And this is the schema I was showing earlier for our Marquee neuroendocrine cancer program. And see, gallium dotatate scan plays a very vital role in helping us manage our low-grade NETs. See, in the high-grade neuroendocrine carcinoma group, it's FDG PET. All right, moving further. Let's quickly talk about, let me check how are we doing with the time. I think I'm really over with the time. So I'm going to quickly zip through this part. How do we treat neuroendocrine tumors? Early stage neuroendocrine tumor, we always prefer surgery if the patient can have, is a good optimal candidate for surgical resection. But the debate is still on for metastatic disease. Unlike a lot of other solid cancers, we do often do cytoreductive surgeries in neuroendocrine cancers, even for metastatic disease. Okay, and because there is no randomized control data suggesting whether surgical debulking does good or not, there is a raging debate in any neuroendocrine tumor meeting between surgeons and med-oncs. Okay, I think I'm a believer in neuroendocrine tumor resection surgeries. During my residency, a lot of my mentors were neuroendocrine tumor surgeons, so I have a little soft spot for resection. I think patients benefit, but you have to pick your patients. You have to make sure it's a healthy patient, can tolerate surgery. But I have seen many patients going 15-20 years, multiple liver lesions ablated or resected, and still NED. So there seems to be that there are patients who benefit from it. Okay, and this is one of our publications. We looked at a long-term database for neuroendocrine tumor resections, and we saw some benefit. Okay. Alrighty. So what about radiation? That's the second pillar of our cancer management. No prospective data that I'm aware of. And so the current role of external beam radiations is very limited to palliation of symptoms if there are bone mets. But really, radiation has not made inroads in neuroendocrine tumors. Maybe this is a really good research idea for a young fellow to explore and maybe design a prospective small pilot study to see what are the response rates in different types. I would expect maybe higher grades would have some roles for sure. So this is the current therapeutic landscape of neuroendocrine cancer, how we medically manage them. As you can see, the lower grades have somatostatin analog. The other interferons, dioxide, we don't use it. Dioxide is more so for insulinoma. The therapy is more shifting to targeted therapies like Afinitor and PRRT. And for high grades, we do cytotoxic chemotherapy, platinum doublet. Okay. Um, I think because of the shortage of time, I'm going to quickly zip through. There are three pivotal studies which were described in the last 3 years. Last 3 to 4 years, which led to FDA approvals. First of it was Radiant 4 study, which led to FDA approval of Afinitor. You can see the PFS curves, 11 months versus 4 months in favor of Afinitor, which is everolimus and inhibitor. And now it's FDA approved for thoracic and extrathoracic tumors. And the recent approval for the other class of drug called pelitrostat ethyl, and it's I think one of the first drugs approved for cancer symptom management rather than tumor management. Okay, and this drug targets tryptophan hydroxylase. This is a rate limiting enzyme in production of serotonin. So if you block this, you decrease serotonin production, and then you help patients with Carcinoid syndrome diarrhea. So they did this large randomized controlled international clinical trial. They randomized patients between placebo and 2 different doses of teletrostat. And you can see here the urinary 5-HIA dipped quite a bit significantly in the treatment arm, which also correlated to decrease in the diarrhea for these carcinoid syndrome diarrhea patients. And this led to FDA to approve teletrostat ethyl as a treatment for carcinoid syndrome diarrhea refractory to somatostatin analog. And this drug works very beautifully, very safe. And then if your patients are on it, then one of the things you do want to counsel them about constipation, severe constipation, sometimes that can happen. It's rare, but otherwise very well tolerated drug. And 250 milligrams CID is the FDA approved dose. And last, to conclude, I think the biggest winner for us and the most recent treatment to get FDA approval was Lutathera, the PRRT, based on a large phase 3 randomized double-blind placebo-controlled trial. No, not placebo-controlled. It was controlled arm was somatostatin high-dose somatostatin analog was NETTER-1. And this is probably one of the best-looking Kaplan-Meier curves you'd ever see in solid oncology. The hazard ratio 0.21. So at the time of reporting this trial and when it got published in AJM, the study arm with lutetium dotatate, which is Lutathera or PRRT drug, did not even reach the median, whereas the control arm with high dose somatostatin analog, I think it was close to 9 months. So, and this data is being followed. I'm sure it will confirm to have overall survival benefit as well. The median PFS is supposed to be somewhere in 35 to 40 range, I think. So based on these stellar results, FDA approved this treatment in 2018. I think since 2019, it's been a pretty accepted and widely used treatment for our progressive gastroenteropancreatic neuroendocrine tumor patients. Okay, I would, I think, hold my further presentation here. I was planning to do some research, slides as well, but I don't think that would be relevant. And plus, we're running short of time. So having said that, there are a lot of other agents currently in development, and we are also developing new agents and starting some new interesting new trials, which maybe in a future talk I can update you guys about. But with that, I would like to thank all of you for being a very patient listener and giving me this opportunity, beautiful opportunity to talk to you guys and tell us what's happening in your tumor. Thank you, everybody. I'm happy to take any questions.
Thank you very much, Aman. That was a wonderful talk with very exhaustive and in detail explanation of the recent happenings in this field of neuroendocrine tumors. We have some questions in the chat box. Maybe we will take a few of them. Um, the the first is, do you screen for a subtype of GEP-NAT at the time of diagnosis? For example, gastrin, glucagon, or somatostatin.
Right. That's a very good question. So in our center, the history really helps us tweak what sort of panel should we order if the patient does have a history which is consistent with, for example, carcinoid syndrome or have profound diarrhea. I do tend to check for serotonin and BIP and gastrin, but I don't order all these blood-based biomarker as a standard on everybody. I think that's where the history is very critical to help us tailor. And to be honest, most of these biomarkers have limitations anyway, so we try to make sure that we don't add to the financial toxicity as well. It really helps in a relevant patient, but I would advise against uh, ordering all these panels on all patients without reason in the history, which will prompt you to check for those biomarkers.
All right. The next question is what? Please comment on the role of NCT, neoadjuvant chemotherapy.
Sorry, I didn't get that. There was some blockage in the network. Can you please repeat it?
Yeah, please comment on the role of neoadjuvant chemotherapy in this tumor.
Neoadjuvant chemotherapy.
Yeah, that's right.
Correct. The places where I have used neoadjuvant chemotherapy or adjuvant chemotherapy in neuroendocrine neoplasm is high grades. Okay, so if we have a patient with high grade neuroendocrine cancer, and we're not talking about neuroendocrine tumor now, high grade neuroendocrine cancer, and this is still early stage, and the surgeon feel that they can potentially resect but they'll need some help because these cancer can be highly platinum sensitive. So we have tried it in that setting. However, most of the patient, in my experience, of high-grade neuroendocrine cancer, even if they're early stage, confers poor prognosis, they don't end up getting surgeries. For your typical low-grade neuroendocrine tumors, we tend not to do neoadjuvant or adjuvant treatment. If they are resectable, we resect them, and that's primarily because most of our treatments for neuroendocrine cancer are cytostatic. So some of our best treatment, for example, Lutathera or PRRT, the objective response rate in NETTER-1 trial was 18%. So even if we give the highly active treatment, the objective responses are not that massive. So this whole idea of neoadjuvant treatment haven't really caught on. There are some pancreatic neuroendocrine cancers which can show some dramatic objective responses to capecitabine temozolomide. So in very select cases, based on tumor board discussion, if we feel that patient can potentially benefit from CAPE-TEM for cytoreduction, and then patient undergoes a surgery, can be selected. But as a general rule, in neuroendocrine cancer, we don't really give neoadjuvant treatment because chemotherapy is not very effective in terms of shrinking the tumor.
Right. The next question is from Kshitij. He's asking, can NET and NEC coexist? And what are your views on doing both DOTA and an FDG PET scan for initial stage?
Right. We do see the situations where we come across a dual histology tumor, sometimes adenocarcinoma with low-grade neuroendocrine tumor, or sometimes NEC with low-grade neuroendocrine tumors. Anytime you have two histologies, you always target your treatment and management focusing on your high-grade cancer, because that is going to dictate the overall prognosis. So if I have a large cell neuroendocrine cancer of pancreas, but I also saw some foci of grade 1 PNET, pancreatic neuroendocrine tumor, I would almost forget that there is a neuroendocrine tumor. I treat these patients like high-grade neuroendocrine cancer of pancreas and direct my treatment based on that. So we will do FDG PET. We will start patients on platinum-based chemotherapy. We might do NGS sequencing, see if we can find targets and screen them for down the road clinical trials. Now, the question regarding should we do both gallium dotatate PET scan and FDG PET? I think this concept is gaining traction. Last year, I was at ENEX in Barcelona. There was a talk on this topic where they were trying to develop a net PET score. And I think I'm a big believer in doing both, but there is a nuance to it. So I would not recommend doing it on everybody. Again, we have to be cost conscious. We have to make sure that the things we are ordering has some value and meaning. Okay, so if overall prognosis is directed by the neuroendocrine cancer, then what's the point of doing gallium dotatate scan? However, sometimes we incur patients with heterogeneous morphology and tumor type disease, where some lesions are photopenic, that means they're not lighting up on gallium scan. In those cases, I do FDG PET to see whether they are truly necrotic lesions or they are actually more dedifferentiated high-grade lesions, because then I might have to switch gears and change therapies. So I am a big believer in doing both, but it cannot be a cookbook decision. It has to be taken, discussed in a tumor board and based on individual patient.
Well, yeah, right. How much time do you have? Can we take a few more questions? Yeah.
Dr. Kulkarni, I would have loved to take a few more questions.
9 o'clock.
How about 2 more questions? I have to run back to my clinic after that. I think I'm already getting pages. But how about let's take 2 more questions and then we can...
I think that's fine. Yeah, I think that's fine. That's fine. So the next is the role of adjuvant chemotherapy, about adjuvant treatment for surgery. And if yes, then what is the duration you recommend?
Yes, sir. So for low-grade neuroendocrine cancers, we do not recommend. There is no good data in support of adjuvant treatment, and that's consistent with our NANETS and I think ENETS guidelines as well. So if you have a grade 1, grade 2 neuroendocrine tumors resected, most likely it's cured. You just need to surveil them with some sort of imaging, and what determines how closely you'll surveil them would be whether the margins were positive, was there neurovascular, lymphovascular involvement in the grade of tumor. But there is no current recommendation to do adjuvant treatment. Now, for high-grade neuroendocrine cancer, yes, if I have a large cell neuroendocrine cancer, and fortunately we found the tumor very early, and based on the risk factors, we probably do some adjuvant treatment with platinum-based chemotherapy. And again, those decisions will be based on whether lymph nodes are involved, how extensive was the surgery, etc.
Right, and so the last question which we'll take now. Somatostatin analogs, PRT, or a combination of both for the initial treatment. How do you choose or sequence? I mean, what are your choices to go?
Yes, that's a very hot topic, the sequencing of treatment. Now, since we have few options, there's always this dilemma about now how to sequence these patients, right? So current standard of care frontline treatment for low-grade neuroendocrine tumor is somatostatin analog. So if a patient needs treatment, there would be a cohort of patients who don't need treatment, and you can observe and look for tumor growth rate and save the patient from getting unnecessary treatment. But now we're talking about progressive disease, patients who are either symptomatic and need some sort of treatment to control their cancer. My go-to drug is somatostatin analog. That's recommended NCCN guideline, recommended various other guidelines, recommended frontline treatment. After that, we now have a couple of options. As for second line, Afinitor is approved for pancreatic tumor, Sutent can be used, and we also have PRRT. And I think it depends on the need for individual case. Just before coming for this talk, I had the patient, brand new diagnosis, who I started on analog and got gallium scan and just reviewed them today. And I uncovered a whole lot more disease, including C3 spine, multiple vertebrae. And this is a patient I cannot wait for cancer to grow further because it's going to affect the quality of life. So this is a type of patient I might pull the trigger on doing PRT sooner than waiting on patient to progress because of just the extent of disease and patient presentation. However, in general, I try to reserve PRRT for a little later. I try to exhaust somatostatin analog followed by mTOR inhibitor and then going to PRRT after that. Again, this is an area of debate, and there are people who like to do PRT sooner. My philosophy is it's a radiation based drug with long term uh, potential sequelae or side effects. So far, PRT has been proven very safe. In short terms, we had no issues, no kidney issues. And there was a recent JAMA Oncology meta-analysis which showed even the myelodysplastic side effects were very few, 2 to 3%, what they found. But again, radiation-based treatment is very limited. You can do 4 doses. There's some upcoming data from Europe that maybe you can repeat 2 more doses if patient had some response down the road. But Yes, but I try to reserve PRT a little bit later when there's true need. PRT works good for metastatic bone disease and a lot of bony mats. So I try to use it for those kind of clinical contexts. If it's a liver dominant disease, I try to use more local regional therapies to control disease like embolization, planned embolization, TACE, and mTOR inhibitors.
Well, I think that probably satisfies everybody. Thank you very much, Dr. Aman. It was a wonderful talk, and it was a pleasure to have you with us. That gets us to the end of the talk. Thank you very much for your patient listening. We'll meet next Tuesday.